So before we jump in and start learning about the important work that the Prevention Institute is doing and their wonderful Thrive framework that they're sharing with us today, I want to go ahead and briefly run through some of the offerings and resources made available through Prevent IPV. For folks who may not be quite as familiar with what Prevent IPV is and what the resources are that are offered, I'll give you a little bit of history and context, and then I'll run through that pretty quickly and try to give the floor over to our wonderful presenters as soon as I can. So a little bit of context on what Prevent IPV is. This was born out of a National IPV Prevention Council that was formed in 2011 and was really a voluntary association of DV coalitions, both practitioners in prevention, executive directors, and a few other folks there too. And the vision for this group was a future in which a wide network of collaborative and sustained primary prevention efforts led to the social change necessary to end IPV. So not at all a tall order. But that's also why there are many projects and kind of iterations and brands that have kind of popped out of this work. So from those initial beginnings, a goal was formed, and this was to create a unified national voice for prevention and specifically for the prevention of IPV. And these are the two things that this group wanted to work towards: promote prevention as a sustainable priority for coalitions and local domestic violence programs. And then, as you see here, the second one, proactively engage federal partners, funders, and allied organizations to promote IPV prevention as a critical component of ending DV and SV. The IPV Prevention Council is made up of a leadership steering committee that consists of these folks here: Christy Van Oudenhove from the Virginia Sexual and Domestic Violence Action Alliance, Deb DeBear from Rhode Island, Janelle Moose from the North Dakota Council, and Gloria Aguilar-Terry from the Texas Council on Family Violence. So one of the things that has popped up as kind of a central organizing area of work for Prevent IPV has been preventipv.org. And on here, over the course of the years that the council has been getting together, there has been an expansion of different resources, new things that have come into our purview. And so I want to very quickly just go through those. If you go to preventipv.org, you'll see at the top kind of a list of all these different offerings. And one of the big things that we try to promote a lot is the tools inventory. What this is exactly what it sounds like. It's a pretty vast, expansive resource library focused on IPV prevention, with the ability to search for programs and resources based on a number of criteria that you might want to pick from. So say you're a prevention practitioner who is trying to, maybe you're at the state level and you're trying to kind of take inventory of what exists as you provide TA for a local program, or if you're a local program or a state coordinator who is just looking for ideas for new work. What you can do is you can go to this tools inventory and search based on whatever you want to look for. Category of work, so you could look for training tools and campaigns. You could look at the strategies that are used, bystander intervention or systems change. And you can even look at these items in this inventory based on, say, media type or settings for use, classroom or community context. And if you know exactly what you want, you can always search for the author or creator using the information that you have. Another thing that we try to promote is that in the tools inventory, we always love for folks, because this work is expanding and constantly growing, and we don't know about everything that's out there. So if you don't find something that you think should be in there, or if you have a prevention project that you think should be included, we really encourage folks to submit their work for inclusion in the inventory. And then those submissions go through a vetting process to ensure that there's consistency with primary prevention frameworks and kind of what we want to promote and see in the inventory. We also have a number of projects on the website associated with engagement and trying to guide folks through the process, whether they be state practitioners or local program practitioners, guide them through the process of engaging specific populations in their Prevent IPV efforts. And so this section focuses on language and techniques for engagement, examples from the field, and there's all sorts of good things there to use, one-pagers to distribute to your community or to whoever it is that you're trying to engage. And soon there will be upcoming video spotlights on engagement successes. If anybody out there is interested, has a really wonderful IPV prevention engagement story that they'd love to tell, we're always looking for folks to highlight in that process as well. And then you'll also find on the website that there's a Prevent IPV newsletter to sign up for. There is a constant stream of news and updates and things like that. So we encourage you to go on there and look through the resources and use those to their fullest extent, and then ask any questions that you have and really plug in any way that you can. Yeah, and that is the spiel on Prevent IPV. We are always, again, looking for more folks to get involved, and we're looking to expand the use of our resources and just to build partnerships with this work. So we encourage everyone to go there and check it out. Now I want to go ahead and introduce our presenters and get to what everyone's here for today, the Thrive framework and the wonderful work that's happening with Prevention Institute. You'll see on your screen today's objectives. We are looking to explore the need for engaging public health sectors and communities in the work to prevent IPV. We want to get your insights and hear from you all through this process. And again, as a reminder, there will be a Q&A section at the end of this series. But we really want to dig into the Thrive framework and really kind of understand what that is as a successful model for engaging in and sustaining IPV prevention efforts at the community level. And I want to stress at the community level, because I think when we talk about prevention along the social ecology, the community level strategies are the ones that we always strive for, that always feel a little bit hard to get at. And I think that Thrive and the PI folks have a lot of insights to offer around this. And then we also want to support you all in utilizing Prevent IPV's online engagement resources and offerings. So today's presenters are Lisa Fuji-Parks and Ashley Crawford from Prevention Institute. Lisa has an extensive background in community development and public health and a wide range of experiences promoting community healing and resilience. Lisa's work embodies a holistic, multi-sector approach to nurturing thriving communities. She has, in multiple contexts, designed, implemented, and evaluated local and state-level prevention initiatives, employing policy, communications, and coalition-building strategies. Basically, Lisa knows everything. Lisa's an incredible resource, and I think we're very fortunate to have her and Ashley both on the call today and to be presenting on this topic. And we're grateful that the Prevention Institute could be here. Ashley Crawford is a Master's of Public Health candidate in the Health Behavior Department of the UNC School of Global Public Health. She received her bachelor's in 2011 in Biology and Ethnic Studies from Davidson College. And she's worked as a project manager for diversity and inclusion and community health at a YMCA of Greater Charlotte. And there she was responsible for implementing a community transformation grant that supported strategies to be inclusive to all members of community, staff, and volunteers. She's also worked as a community organizer in Washington, D.C., and was a 2011 Barbara Jordan Health Policy Scholar. So we are incredibly excited and, again, fortunate to have them here today. Lisa and Ashley, thanks for being here, and now you have the floor. It's all you.
Wonderful. Thank you so much, Jonathan. Thank you so much, Casey, and welcome, everyone. We're really excited about today's web conference. I'm Lisa.
And I'm Ashley.
Ashley, hopefully you can hear both of us. Let us know if you have any sound qualities, issues. And Casey Castaldi is also in the room. She's web teching for us today. Thank you, Casey. We're from Prevention Institute, and Prevention Institute is a national nonprofit organization working to promote health and safety and health equity with a focus on primary prevention. And we're really excited to present this content for the first time to all of you. Okay, so Jonathan had his overall objectives for today's web conference, and I'm going to just describe the content of my piece here, which is we're going to provide an overview of Thrive, which is a framework and tool to address the social determinants of health at the community level. We're going to talk about the community determinants of intimate partner violence, specifically using Thrive. And then we're going to explore how Thrive could be used as a framework and tool to support local IPV prevention efforts in diverse community context. So this webinar really emerges out of kind of a growing collective understanding that the social determinants of health need to be addressed in order to address issues like intimate partner violence, but also the recognition that there aren't a lot of frameworks that have really tried to understand intimate partner violence from a social determinants of health approach. So, you know, folks are asking questions like, well, what are the social determinants of health for intimate partner violence? And how do we go about working on these in communities? And how do we address issues of equity in the process when we're working on such broad community-wide factors? So in this webinar, we're going to try to take a look at some of those questions. And I did want to really note that today's webinar is an overview. It's not going to provide you with a lot of detailed guidance on how to use Thrive or concrete examples of how Thrive's been used for IPV, because the reality is actually that Thrive, to our knowledge, has not been used for intimate partner violence prevention. So our time today is going to be really providing an overview of the framework and exploring with you how it could be used. So just want to make sure that folks have realistic expectation of what's going to happen. The work that we're going to present comes from a report that PI prepared for the Blue Shield of California Foundation, and we're really grateful to Lucia Corral-Pena and Marissa Tirona and others at the foundation who supported this work and guided our process. We're going to be doing a soft release of this report later this week and a more formal, bigger push in October during Domestic Violence Awareness Month. So we will make the soft release version of the report available to you if you're interested in taking a look. We'd also be interested in hearing if you would like to know more about Thrive. Please contact us if you have ideas about how we can be supportive to your work, or if you're interested in somehow using some of the ideas or the content here during Domestic Violence Awareness Month coming up in a few months. There were a lot of folks who helped us with developing this report. We drew on the literature base, both research literature as well as gray literature, and the expertise and insights of over 30 key informants. And also we drew on analysis conducted by Prevention Institute using some of our core tools and frameworks. But I really want to especially thank all the folks who are listed here, whose insight really helped to pull this entire piece of work together, and without whose input it would not exist. So on that note, let's begin to think about how to apply a social determinants of health framework to intimate partner violence prevention with some interaction using text chat. And we're going to show some images, and we would like for you to use the text chat to let us know, what does the image have to do with intimate partner violence? So here's our first image. So go ahead and use the text chat to type in your thoughts. What does this image have to do with intimate partner violence? And we'll give folks a couple of minutes to go ahead and put their answers in. Let's see, Jean Marie says objectifying the woman, desired appearance and roles, subservience, rigid gender roles, and community support, demeaning intimate relationships. Jordan's talking about gender stereotyping, and Elise treating women as objects. Right. So this is an advertisement, and this is the typical kind of stuff that you might see on a store wall or a billboard, that kind of thing. And the way that folks are talking about that oftentimes our media and our marketing practices can really reinforce harmful norms and culture that are associated with the domestic violence or intimate partner violence. And media products that objectify women may play a role in creating environments that are conducive to intimate partner violence through the content and the marketing that propagate harmful gender norms and normalize violence. So the text here is to see it is to want it, and folks are really, Colleen is talking about this as well, that the beer and the woman are promoted as going together, and
if you see it, you want it, you can buy it, you can have it. So let's go to the next image. And how about this image? This image comes from Restaurant Opportunity Centers United. It's an image of people demonstrating to promote the One Fair Wage campaign, which is promoting legislation in cities and states to require the restaurant industry to pay all of the employees at least the regular minimum wage. So what do you think? What does this image have to do with intimate partner violence? All right, so Dana says that the campaign will allow women a living wage and to decrease their dependency on another. So a living wage or the lack of the living wage can promote dependency. Or Casey is saying bridging income disparities across gender allows for greater agency. So agency as opposed to dependence. Promoting an environment of fairness, Russ says, at least measured by wage. And also men and women sharing public space. Great. So, and Casey's talking about intersecting our work with economic justice. So in our research, family and community economic insecurity was found to be associated with higher rates of intimate partner violence. And this campaign is showing one effort to address one of those sources of family and community economic security. So the restaurant industry is one of the only industries that gets away with, in 43 states, not paying the great majority of its workers, including servers, bussers, hosts, and bartenders, at least the minimum wage. So contributing to family and community economic insecurity. And those factors can show up in other ways in families and communities, such as high unemployment rates, concentrated poverty, neighborhood disadvantage. And we know that intimate partner violence occurs in relationships across all socioeconomic factors, but there's really strong evidence that does indicate that the risk is greater in communities with higher neighborhood poverty and unemployment. So there's a lot of different ways that researchers hypothesize that this occurs, but one of it is that concentrated socioeconomic disadvantage leaves families and entire communities deprived of economic resources to meet their basic needs, and increases levels of family and community stress, conflict, and instability, which in turn increase the likelihood of intimate partner violence. And also there are other ways that concentrated socioeconomic disadvantage contributes to other factors that are associated with IPV, including low social capital and weak community sanctions against IPV. So there are probably a number of different ways that these factors are connected to increased risk for intimate partner violence. So when we're talking about social determinants of health, we're really talking about these kinds of factors and how they relate to intimate partner violence. When we think about things like media and marketing practices or family and community economic insecurity, one question is, are all communities impacted in the same way? And already by folks' text chat response, I can see that folks are saying that no, that's not the case. There are a lot of inequities playing out. And we know that the U.S. has really vast inequities in factors like economic wealth. So how do these inequities shape intimate partner violence? So I'm going to turn it over to Ashley, who's going to talk about this in the context of Prevention Institute's home city, Oakland, California.
Thanks, Lisa. So Lisa and I were reflecting on how systemic inequities play out in the community where PI's headquarters are located in Oakland, California. And the factors that Lisa just highlighted play out in Oakland in a number of ways, and we can really see that when we compare across zip codes. So a study by the Alameda County Public Health Department found that an African American child born in West Oakland can expect to die almost 15 years earlier than a white child born in the Oakland Hills. And this really gets at the heart of what we want to talk about today. These inequities are unjust, and they aren't the result of differences in these two children. They're a result of the environments in which these children grow up. Inequities also exist in rates of IPV. This map of Alameda County, where Oakland is located, depicts the total number of partner assault emergency department visits. And you can clearly see that there are two geographically different areas in the county with substantially different numbers of visits. And more often than not, the areas of the map that have more emergency department visits are also the communities that are predominantly people living in poverty and or people of color. And so in addition to IPV inequities existing by place, they also exist by race. For example, data from the Alameda County Family Justice Department shows that DV victims in Alameda County are 4 times more likely to be African American, despite African Americans making up only 12% of the county's population. And so we see that the same communities that have disproportionately lower life expectancies also have more visits to the emergency department as a result of partner assaults and are more likely to be DV victims. This is not a coincidence. These health inequities are a result of historical and present-day policies and practices that perpetuate a system of diminished opportunity for certain populations. And while studies are few and have their limitations, inequities in rates of IPV are also seen by gender, socioeconomic status, age, sexual orientation, gender identity, and other factors. Our goal as prevention practitioners is to achieve health equity, which means that every person, regardless of who they are, has an equal opportunity to achieve optimal health. So to address inequities, we need to change the policies and practices that promote them. But so often, prevention work focuses on changing the behavior of individuals. Prevention Institute has a tool to help us understand how policies and systems shape conditions in our communities and how taking action, particularly at the community level, is critical to reducing inequities and promoting equity. I'll pass it over now to Lisa as she will share more about PI's tool, 2 Steps to Prevention.
Great. So obviously inequities exist in intimate partner violence, and it's important for us to acknowledge that and to think about what is leading to that, and therefore what do we need to influence, not only to address intimate partner violence, but to also address the inequities in intimate partner violence, and also to not take actions that could potentially exacerbate inequities and in fact potentially reduce rates of intimate partner violence overall, but exacerbate inequities, so improve conditions for some folks while not improving it for others as well. So how do we do that? So let's take a look at another Prevention Institute tool called 2 Steps to Prevention, which is going to help us think about the relationship between IPV and inequities in IPV with exposures and behaviors that affect these outcomes and the environment that shapes patterns of exposures and behaviors. So first we start with the condition that we're concerned about, and in this case it's IPV and inequities in rates of IPV. So let's take a first step from thinking about that to identifying the exposures and behaviors that are associated with IPV. So we conducted literature review and interviews and conducted synthesis to identify a number of exposures and behaviors that are associated with intimate partner violence, including the list that you see there: history of multi-generational violence, history of witnessing violence, social and emotional isolation, lack of healthy role models in relationships, and so on, down to adherence to gender norms related to inequities, violence and non-intervention, awareness of lack of community sanctions, and desire for power and control in relationships. Those are the exposures and behaviors that are associated with IPV and inequities in IPV. Let's take a second step to understand what the role of the environment is, or what the role of social determinants of health are in shaping these exposures and behaviors. And what we call the environment is also referred to as the social determinants of health. And social determinants of health include structural drivers and community determinants. So first, structural drivers. So the World Health Organization, that's really been a leader in helping change public health practice across the globe, had really helped us to understand what structural drivers are and how they shape outcomes. The WHO identified structural drivers as the inequitable distribution of power, money, opportunity, and resources, and that these are a key determinant of inequity in health and safety outcomes across the globe. At a fundamental level, inequity in health outcomes can be understood as disparity in power. Groups with less power, systematic less power, tend to suffer worse health outcomes.
So structural drivers also influence health outcomes because they shape the circumstances in which people are born and grow, live, work, and age. So the WHO also identified community environments or community determinants as key contributors to inequities in health outcomes. So structural drivers like racism and socioeconomic inequity play out at the community level to deeply impact community conditions. And research has shown that after adjusting for individual risk factors, there are neighborhood differences in health and safety outcomes. And so the environments in which we grow up, our community environments really do fundamentally impact health, safety, and inequity. And importantly, they represent a place where we can take action to promote equity in health and safety outcomes. So with this framework of understanding the importance of focusing on structural drivers and community determinants, Prevention Institute conducted a scan of the body of available research, particularly on community-level risk factors associated with intimate partner violence. And we also looked at resilience factors associated with what we were calling safe relationships. And so through interviews with practitioners, advocates, and researchers, we also asked about their understanding of community determinants to help us identify 6 community determinants for which there is research and practice-based evidence of association with IPV. So I could say a lot about the research process. If you take a look at the paper, it'll explain it in a lot more detail. What I will say now is that our scan was extensive, but what we are going to present to you is not an exhaustive catalog of community-level factors. The determinants we included were based on strength of evidence and recommendations from advocates, practitioners, and researchers, but the lack of evidence supporting a link between a particular factor and IPV does not necessarily mean that a connection doesn't exist, but just rather that the research was not found that demonstrates such a connection. So that brings us to Thrive, our framework that we are highlighting today. So our findings from the literature and interviews really aligned well with Prevention Institute's Thrive, which stands for a tool for health and resilience in vulnerable environments. And Thrive is a community resilience framework. It was developed with the intention that there are important assets in communities to build on, and that communities can become healthy and be healthy and safe, even in the face of structural and systemic challenges, and that a resilience orientation to our work and an assets orientation to our work is really important. So Thrive is both a framework and a tool. It can be used by community members, coalitions, public health practitioners, local decision makers. And as a framework, it's a way of thinking upstream to address social determinants of health. And as a tool, it's a way of moving forward to act on the upstream social determinants of health. So let's take a closer look at Thrive as a framework. So as a framework, Thrive helps to understand how structural drivers play out at the community level to impact community determinants and consequently health and safety outcomes and inequities in those outcomes. Thrive identifies 12 community determinants of health and safety grouped into 3 interrelated clusters: the social cultural environment, or the people cluster, the physical built environment, or the place cluster, and the economic educational environment, or the equitable opportunity cluster, or the opportunity cluster. So just a little bit of background. We wanted to let you know that Thrive was created over 10 years ago. We started the process of developing Thrive in 2002. And it was an iterative process of scanning peer-reviewed literature, reports, and conducting interviews with practitioners and academics, and involving a national advisory group. It was a several-year process of developing the tool, and a collaborative way of arriving at this understanding of the 3 interrelated environments and the 12 factors within those clusters. Thrive was updated in 2011 and 2012 based on a more recent review of the social determinants of health literature. So we made additions and tweaks and changes to strengthen and update the tool just a couple of years ago. And the language of Thrive was developed by piloting and gaining feedback from communities with the goal of incorporating community-friendly terms rather than the research academic language. So if you're wondering, how do some of these terms relate to research academic language, that background information is available. But we wanted to try to take some of that jargony research academic language and use terms that were more community friendly and the way sort of people normally talk and think about things, and hopefully make it more accessible. So applying Prevention Institute's Thrive framework, the 6 community determinants for which there is evidence of association with intimate partner violence were organized into the Thrive 3 interrelated cluster: people, place, and equitable opportunity. And there you see the 6 factors that we found association with intimate partner violence. And I'm going to talk a little bit more in depth about what those are. One thing that's really important to note is that no one determinant alone can be attributed with causing the exposures and behaviors associated with IPV or preventing those exposures and behaviors. It's really the accumulation of the determinants of DV without compensatory determinants of safe relationships or resilience factors that increase overall risk. And these determinants are really interrelated and influence each other in numerous ways. So for example, we have housing insecurity listed here as one of the determinants for which we found evidence. Well, housing insecurity has a really strong influence on other factors like social networks and trust. Housing insecurity can really compromise social networks and trust within a community. And in turn, housing insecurity and diminished social networks and trust can contribute to harmful norms and culture. So these all relate and interrelate and reinforce each other. So let's take a look at the factors in each environment, starting with the social cultural environment, or what we call the people cluster. And I want to make sure that we are getting some text chat interaction. So as I talk about these factors, we would like you to text chat with us about how these factors in the social cultural environment shape intimate partner violence in your communities. We'd really love to hear that from you. So, so the social cultural environment, starting with harmful norms and culture. So harmful norms, such as norms that support gender inequities in relationships, and norms supportive of violence, and norms of non-intervention in family matters, reinforce power disparities within relationships and condone the use of violence to solve problems, and they discourage community intervention. So we found evidence of association of these 3 types of harmful norms and culture with increased risk for intimate partner violence. Again, the research is all in the report, so if you want to check that out, please do so. I'm not going to go into detail of all of these factors right now, but just want to give you a basic sense of what we're talking about. So by weak social networks and trust, weak social networks result in distrust and increased social isolation within communities, and that is a known risk factor for intimate partner violence, whereas social cohesion improves trust and solidarity between community members and can foster healthy community relationships. And so we group those related factors under social networks and trust. Excuse me. And then low participation and willingness to act for the common good, again, kind of not a research-based term, but in this case applied to intimate partner violence really is referring to what we know as weak community sanctions. In other words, the lack of moral, social, and legal pressure from the broader community to intervene to address and prevent IPV. and this reflects low community capacity to address and prevent IPV as a community issue. So low participation and willingness to act enables perpetrators to use violence with relatively little fear of repercussion while discouraging survivors to seek support. And all of this contributes to a greater likelihood of intimate partner violence perpetration. So I'm going to take a moment to ask Casey Keene from National Resource Center on Domestic Violence to just let us know what she's seeing in the text chat so far. Casey, if you wouldn't mind just giving me a flavor of what folks are talking about so far, and if anything has come up specifically related to this social cultural environment. But first, if you wouldn't mind just bringing me up to speed on what's happening.
Yeah, I'm so glad for the opportunity, Lisa, because there's been some discussion about the relationship between structural drivers and community determinants. Not really being clear on are those the same concept, and there was some sense that the structural drivers, and it was great, Jean Marie was talking about the fact that she believes that structural drivers may be the larger, less accountable forces that produce the community determinants that are then easier to see and quantify. So we just had a little bit of confusion around the relationship between those two concepts.
That's a great question, and I'm so glad that you're, causing us to pause to really talk about that. It's so important. So I think it's complex. I think for the most part, I agree we can think about structural drivers as those forces that are kind of beyond the community. They might be operating at a national or even international level. These are things like our basic economic structure of our country being that of capitalism, or laws and policies that are set at the national or even international levels that shape civic participation or other ways of having power within society or not having power within society. So I agree with that description, that it's sort of the less accountable. I like that, beyond the community. But at the same time, we know that these factors play out at the community level and are built into our community level. Our local policies, our local practices are also both operating within those larger structural systems and acting as reinforcers or promoters or of perpetuators of those structural drivers as well. So we try to represent that by showing the structural drivers. The structural drivers are broader than the community determinants, but the community determinants are kind of operating within those structural drivers as well, as how we try to represent that visually.
And sort of a related conversation, so Russ was asking about, where from the World Health Organization, where you could find more information about these concepts. And so Jonathan did share a link to WHO's publications around social determinants, and I shared some of their key concepts and definitions. We didn't know if there was a particular WHO publication that you could recommend for those who are interested in learning more about this.
Yeah, that's great. So the World Health Organization came out with a seminal document in 2008, and I don't have the name of it in front of me. I should have it committed to memory, but that really, kind of was the main document that has pushed this conversation around social determinants of health forward globally. And maybe if someone else on the PI team could look that up. We cite it numerous times in our this report that we're referring to. And another resource that you could take a look at, I mentioned that we updated the Thrive research in 2011 and 2012. And in order to do that, we compared, I think, around 20 social determinants of health frameworks, how they were defining social determinants of health, what they were including or not including, how that was similar or different from the Thrive framework. incidentally, we found that there was a lot of overlap. There were some interesting distinctions, but we drew on what we learned from those other frameworks to update Thrive. But all of that is to say is that all of those frameworks really do cite that 2008 WHO document as kind of a seminal and critical document. And great, it looks like Casey has posted it for everyone. So a little bit of history and worth checking out. Yeah, so hopefully that addresses that question. Anything else, Casey, that you see coming up?
I think that covers it so far. Thanks for checking in, Lisa.
Okay, great, great. So, really encourage you to think about whether these factors are resonating for you and what you know from your communities as being associated with IPV, or if it does resonate, sort of how does it resonate and how does it interact with other factors. So let's look at the built physical environment, or the place cluster. We found that housing insecurity, which can include difficulty paying rent or bills, frequent moves, and overcrowded living conditions, to be closely linked with increased risk of IPV. And there's, again, I don't have the time to go into the details of it, but there's really interesting literature connecting both housing insecurity and affordability issues with IPV, and less so, but still very interesting, some aspects related to housing design and intimate partner violence. Another built physical environment factor is what we're calling harmful media and ways of promoting products. But there's two aspects of this that I want to pull out. One is that there's an association of high alcohol outlet density and availability is correlated with higher rates of IPV, whereas low alcohol outlet density is associated with reduced rates. So that is one of the products that's promoted and sold in the environment that is associated with IPV. Also, media and marketing practices, we talked about that a little bit earlier when we showed the image of the beer advertisement. Media and marketing practices that reinforce harmful norms and culture are also associated with harmful gender norms and intimate partner violence. So I talked about that quite a bit earlier, so I won't go into that more now. So encourage you to think about, if we haven't, how do these factors in the built physical environment shape IPV in your communities? Do you see an association? Do you not see an association? Why or why not? Would love to hear what folks are thinking. So the next is the equitable opportunity cluster, and what the factor that we found associated with IPV here was family and community economic security, and I talked about that earlier when we talked about the wage campaign. One thing that I wanted to note, which might surprise folks, is that we didn't find an association between academic achievement and intimate partner violence, at least at the community level. So we do know that at the individual level, low academic achievement has been established as a risk factor for intimate partner violence, victimization, and perpetration. So we do know that educational opportunity or educational achievement is associated with increased or decreased likelihood of IPV. However, when we looked at the research at the community level, or when we looked at the findings on the influence of education on prevalence at the community or neighborhood level, the findings were really mixed. So we weren't exactly sure what to do about this, but what we basically landed on is that education is clearly linked to factors like poverty and economic insecurity, which is associated with IPV. However, according to the most recent systematic review of research that we found in the U.S., was that at the community level, the relationship between educational attainment and intimate partner violence prevalence may not be significant when economic factors are controlled for. So we did not include education as a community determinant in this paper. And I think it's interesting to look at populations in your community, who is having high levels of academic achievement and yet might still be at a higher risk for intimate partner violence, because that's sometimes what we actually find. So one of the handouts that we provided for this web conference is a summary of these 6 factors, how they relate to the Thrive tool, and also how they relate to the resilience factors. And so hopefully you've had a chance to download that handout. If not, perhaps you could do that after this web conference, or again, you can look at it, the details of it in the paper. So in our framework, this shows the community determinants of violence in the inner circle and the 6 factors that I just discussed. And there's a couple other things happening in this that I want to describe to you. First is that we included what we were calling overarching community factors, and we included community violence and community trauma as overarching community factors. So I want to explain our thinking in that. Community violence is the intentional acts of interpersonal violence committed in public areas by individuals who are not intimately related to the victim. Exposure to community violence and the subsequent trauma is associated with many of the factors that increase the risk for intimate partner violence, such as family and community economic insecurity. There is a strong association, or exposure to community violence is a recognized strong factor with a strong connection to intimate partner violence. So we thought that it was really important to include exposure to community violence, or the presence of community violence, as an overarching community factor. We also wanted to include community trauma. And by community trauma, we're referring to the cumulative and synergistic impact of regular incidents of interpersonal violence, historical and intergenerational violence, and continual exposure to the impact of structural drivers of inequity, what some, including PI, what we're increasingly referring to as structural violence. So the violence of living in an inequitable system and living under inequitable conditions. And we're really finding that community trauma is an overarching factor. It's not just the aggregate of individuals in a neighborhood who've experienced trauma, but there are manifestations or symptoms of trauma at the community level that are both shaped by these factors that are listed here as community determinants of IPV, and also impact those factors as well. So again, an interactive relationship between community trauma and these factors. So for example, in the U.S., the destruction of Native American cultures, families, and traditions and lives at the hands of European settlers resulted not only in individual trauma, but in the community trauma of the entire Native American communities. And this impact of multi-generational community trauma has included dramatic impact on family structures and power dynamics within these relationships. There's a lot of research that says that the impact of this has contributed to increased rates of intimate partner violence within cultures where it was previously not the case. And you can also think about other communities that face that kind of systemic or structural violence and multi-generational trauma, and how those factors might also be contributing to higher risk of intimate partner violence. We talked about structural drivers earlier, and so here we're representing that visually to show that issues like structural disempowerment and disenfranchisement and unequal distribution of power and resources are continually influencing these community determinants and playing out at the community level and shaping these conditions. With that, I want to go back to the question that I asked Ashley earlier today and say, what's health equity got to do with it? How are the structural drivers playing out in the environment to affect IPV and safe relationships? So let's revisit this question for a second. So again, looking at the same image, what about this image? How are the structural and equitable distribution of power, money, opportunity, and resources playing out here, or in environments where you might see an image like this? So we'll give folks a minute to text chat about that. So you might see an image like this in your community. How are the broader structural and equitable distribution of power, money, opportunity, and resources playing out in this image or in the existence of this image in the community environment? Okay, so folks are hopefully text chatting away or thinking about what they might want to text chat, but I'll just pose a couple of follow-up questions. In which communities are you more likely to see this kind of advertising? Who do corporations target for this kind of pushing of these kinds of products or these kinds of norms? Julie talks about promoting sort of a vacationing that might not be accessible to many people economically. When you think about things like corporations targeting particular communities, low-income communities, communities of color with this kind of harmful advertising, concentrating it in a way that you might not see in other neighborhoods, you can really see those structural racism, structural inequities playing out. There are also real historical and structural reasons why certain neighborhoods have higher concentration of alcohol outlets. And in fact, banks tend to, there's some documentation in our paper where we talk about lending practices where banks actually would push small business owners or people of color who are interested in opening small businesses to push them in the direction of opening liquor stores, which contributes again to the higher concentration of alcohol outlets and the higher prevalence of this kind of marketing in communities. So let's take a look at the next image. So how are structural and equitable distribution of power, money, and opportunity playing out here? I can give you a minute to text chat about that. So some really good comments about where people are really teasing out these kind of how these structural factors are playing out in a number of different ways in these images. And we kind of, we could probably talk about them for a long time if we had the opportunity to make all of the various connections. But I think the point is to really think about, to not just think about housing generically or jobs generically, but that it's important to really be thoughtful about how are structural inequities playing out in your community in factors like housing, and so that when we talk about addressing housing as a factor for intimate partner violence, we're not saying generically, oh, just get behind building housing, any housing for anybody. But we're really talking about being very thoughtful about the specific ways that housing instability or unequal access to affordable housing plays out in your community in ways that specifically increase the risk for IPV for certain populations, and to focus on solutions to housing for those populations that address the specific ways that inequities are playing out and impacting their lives. And this image is about wages, but you can, everything from looking at it at the national level with the lobbying power of the National Restaurant Association and Fortune 500 restaurant corporations, you can see how wages are suppressed for certain types of employees because of these systemic inequities. So when getting behind issues related to wage campaigns, really looking at the ways that female workers, immigrant workers, workers of color are, because of these structural reasons, disadvantaged and not having the same access to economic opportunity as others, you can really make a strong case for how a living wage campaign or a wage campaign in your community might address family and economic security in the particular ways that structural inequalities are shaping that. So we've presented a lot of information. I want to show you all of that information put together, this framework that shows the relationship between structural drivers, the community determinants of domestic violence, the overarching factors of community violence and community trauma, how they are shaping exposures and behaviors in our communities, and therefore resulting in both intimate partner violence but inequities in those rates of intimate partner violence. And this is kind of it's complex in and of itself, but it's meant to actually simplify and illustrate the continuous and reciprocal interplay of factors within the environment and how they shape outcomes. So it's complex, and yet it doesn't even fully demonstrate all the complexity, but hopefully paints a picture of what's happening. And we also in our paper took the time to try to take a resilience approach and to identify resilience factors that could promote safe relationships, structural drivers that could promote structural equity, and exposures and behaviors that we believed would result in safe relationships and reduced rates of intimate partner violence. So before we go to Thrive as a Tool, I'm just going to say a little bit more about the paper that we developed for Blue Shield of California Foundation. And I'm going to stop here in terms of talking about the framework, but I did want to let you know that in that paper, we identified 12 key sectors that can significantly influence the factors in the community environment associated with DV. And we conducted a preliminary analysis using Prevention Institute's Collaboration Multiplier tool to identify opportunities for those 12 key sectors to influence those community determinants, and also to explore how those sectors could come together, two or more sectors at a time, to really address the interrelationship between the factors and enhance outcomes. So all that information is beyond the scope of today's presentation, but it's available in the report. And now I want to give it back to Ashley to talk about how the Thrive framework can actually also be used as a tool.
Thanks, Lisa. So Thrive can be used as a tool for engaging community members and practitioners in assessing the status of community determinants, prioritizing them, and taking action to change them to improve health, safety, and health equity. And so as Lisa was discussing, Thrive is definitely a framework for how to think upstream, but it's also a tool that supports action moving upstream. And Thrive has 5 steps. These steps are not linear, but rather they're iterative and also mutually reinforcing. And so the steps include engaging and partnering with communities, fostering a shared understanding, assessing the status of community determinants, planning and taking action, and then also measuring progress. Right now we're going to ask another text chat question to everyone. We'd like to know how you've implemented some of these Thrive steps in your work. And we're going to give an example of each step now. Like, I'm going to hand it over to Lisa, and she's going to go through our steps. And as we do that, we encourage you to share your experiences.
Great. So the first step in the Thrive tool process is to engage and partner. It's so important to think about who needs to be engaged: community members, people affected by the issue, organizations that can take action, that have different resources and capacities. So I imagine that you engage and partner lots of different community members, community organizations in your IPV prevention work. And in this case, the point is to really think about who needs to be engaged and who to partner with in order to influence the community determinants of IPV.
So PI had the opportunity to support a process in Alameda County using and adapting Thrive through a project called the Eden Area Livability Initiative, or ELI. And ELI made community engagement and creating safe spaces for community voices a constant priority. The initiative reached out to 40,000 residents through flyers and a task force, presentations and forums, meetings at church groups, ESL classes, and parent-teacher meetings. And as you can see here in the photos, they intentionally engaged Spanish-speaking residents through meetings facilitated in Spanish, and engaging a youth leadership committee was particularly important.
The next step is to foster shared understanding and commitment to promote understanding that the key determinants of health are at the community level, or to promote understanding of social determinants of health. And I have found that this step is so important and can be very transformative for work, not just on IPV prevention, but on a number of different issues, and that it's really helping people to think about root causes or underlying conditions, and how we have so much shared interest in addressing these upstream determinants, but it's really important to take the time to foster that shared understanding and commitment. So we're really interested in the next question, the text chat question, the next text chat question, which is, what are the ways that you have fostered shared understanding and commitment in your community in the work that you do? What has worked? You know, have you done photo voice? Have you done workshops? What are the ways that help people to really understand how the social determinants of health are playing out in communities to create inequities and poor health outcomes, poor health and safety outcomes?
And to go back to our example, in terms of fostering a shared understanding among community members, the ELI initiative used town hall meetings and a presentation on visualizing a healthier community. Through the town halls, the initiative really took the time to ensure that community residents understood the underlying factors that shape health and safety concerns and outcomes. And in this case, these were called livability factors, and they were an adaptation of Thrive factors and another existing list of factors that the community had already created. This example really shows not only how important it is to build collective understanding of the roots of community challenges, but also that education needs to be done in a way that's relevant to the community and fosters buy-in. We really support Thrive being used and adapted in whatever ways make the most sense for a community.
So I'm going to take a pause here and go back to Casey to see what's coming up in the text chat, additional questions or comments that it might have come up, or how folks are responding to our discussion of how to use Thrive as a tool.
Thanks, Lisa. So I think participants are finding that they are, in fact, implementing these steps, even though they might not have been framed in that way in the past. So Russ talks about how he's been implementing step one through his work to engage and partner with men throughout the community and organizational partners like area universities, the Muhammad Ali Center, local soccer team, etc. So he's just talking about how, without naming it as a process, it appears that they have been actively engaged in that first step. And when it comes to step two, Julie is talking about going into schools and talking about how bullying and anger management issues may lead to domestic violence. So I think participants are finding that these steps are resonating.
Great. So, probably these 5 steps looks very similar to public health approaches that we might take on a number of different issues. And so yes, they are kind of the same. What we've tried to do with the Thrive tool is to find a way of doing that process that really helps people to arrive at an understanding of the importance of addressing the social determinants of health. And so kind of in the way that your understanding of the roots of a problem are going to shape the kinds of solutions that you are going to want to take or that you think are going to be effective. And so really building into your community planning, community engagement process, very intentional ways of helping people to understand these broader structural drivers and these broader community determinants, so that the solutions end up addressing those issues, as well as some additional, what we might call quote-unquote downstream factors that are also important to address. But, having a very intentional process to help people arrive at the determinants of health can be really important. And we have a lot of materials that you can download from our website about Thrive that are really, again, designed to do that. And we'll continue to develop more resources as well. And I see Colleen says, because these can be complicated conceptual issues, especially for non-public health partners, we've tried to use activities to demonstrate the connections and impacts among structural determinants and violence. So I'm totally curious, Colleen, about what kinds of activities you've done to demonstrate the connections. So I'm not sure if you're willing to share there, but that's definitely along the lines of what we're trying to encourage in the use of Thrive as a process. Okay, so the third step is to assess. And we do have an assessment worksheet that can help communities assess the 12 Thrive factors. And we like to think of it in terms of assessing assets and needs in a community. So folks can think about where are we strong, where are there gaps and needs, and what are our particular health concerns and inequities. So the Thrive tool, the way that it was originally designed was for a community to come together and to really identify the assets, needs, and concerns without a preset agenda or issue identified. But that said, I think that the Thrive as adapted to IPV could certainly be used to take a look at, of the 6 community determinants that we've identified that are associated with IPV, which ones are most concerned in our community, how are the structural drivers playing out in these factors in our community, and which factors do we want to prioritize taking action on. So the assessment could be broad and across multiple issues, or it could be tailored to be specific to intimate partner violence. So that is an image of the top of the community assessment worksheet. And folks can use this worksheet with community members to conduct the assessment. And communities have typically supplemented the assessment worksheet with other forms of data as well, existing data sets that a city or a neighborhood might have collected, or potentially collecting new data through focus groups, surveys, photo voice, and that sort of thing.
Great. So back to our example. The ELI assessment process had 2 steps. In the beginning, they reviewed over 55 county and special district plans and reports, and then later they hosted community charrettes, which are collaborative and open community meetings designed to solve problems and advance change. In the 2 phases of the initiative, they engaged over 700 community residents at these charrettes to vote and prioritize the different livability factors that you can see in the photo and discuss next steps.
So the next step is to plan and act, and this involves clarifying your vision, your goals, your directives, establishing decision-making processes and criteria, and implementing a faceted set of activities to achieve desired outcomes. And again, here's where we can bring in some knowledge about how to change social determinants of health, including through working through a multi-sector coalition, working comprehensively across the spectrum of prevention to include policy and practice change, as well as other efforts, those kinds of things, where we're ensuring that the kind of actions that we are planning for are really the kind of actions that can lead to impacting the social determinants of health.
So with the ELI initiative, after the community charrettes, they developed a list of prioritized projects, and task forces were established in phase 1, and then working groups were established in phase 2 to take action moving forward. Some of the priorities from phase 2 are pictured here, and a few that came out of phase 1 included changing the planning commission representation to reflect the community, school and neighborhood-based violence prevention and injury reduction project, and then also a teen center in the Ashland community.
So the next step is measuring progress, and again, these steps aren't linear, but we're kind of revisiting each step, iteratively along the way. But measuring progress can be really important in ensuring that communities are using resources in the most effective and efficient manner, and that efforts are accomplishing the desired outcomes. And I know from speaking with a lot of folks working on IPV prevention, there's been so much great thinking in terms of what kinds of factors and progress can we measure in the short term, in the intermediate term, and in the long term, knowing that addressing these complex factors that contribute to intimate partner violence are such long-term efforts, but we can really come up with theories of change of what are some of those intermediate markers that let us know that we're going in the right direction.
So with the ELI initiative, each priority had many short-term goals, and since we don't have time to focus on all of them, we'll just highlight the major steps from one of the priority projects, which was developing the youth center in Ashland. And so some of the steps that the initiative took to achieve this goal included first finding a space and purchasing land, undergoing a master planning process with an architect, which included forming partnerships with 3 local agencies, organizing for youth leaders to meet with architects and the Arts Commission on conceptual building design, and then also conducting a survey of 300 youth, selecting a lead operating agency for the youth center, which ended up being the Alameda County Health Services, and then also partnering to design the open house for the youth center. And the ELI initiative continues to have successful outcomes based on the priorities that were developed with community. And one successful outcome from the work was the opening of the Reach Ashland Youth Center, which now provides recreation, education, arts, career development, and health services to local youth.
The ELI project, the story that Ashley told, really resulted in a lot of different outcomes. The Ashland Youth Center being one super impressive one that took about 10 years to accomplish. But in the process, there were so many accomplishments along the way. Increased civic engagement, particularly among young people, which we talked about participation and willingness to act for the common good being a factor that's associated with IPV, or an increase in that associated with a decrease in IPV. Also, a shared vision for the future of the Eden area, additional goals and projects, increased collaboration, increased investment by government and businesses in the area, etc. And so a lot of outcomes that connect to different aspects of what we've talked about in terms of the community environment that is related to intimate partner violence. So we would love to hear your thoughts about in what ways does the ELI story connect for you to IPV prevention work. Do you see connections between the story that Ashley told and intimate partner violence prevention generally? Do you see connections between the specific work that was done and specific issues in your community? For example, I know that a lot of SDV or intimate partner violence prevention folks work on youth engagement and youth leadership as an important strategy, and that's an important strategy that was used in the ELI story as well, that the community really prioritized. So I'd love to hear your thoughts on that. And that concludes our presentation. We would love to encourage you to visit our website. I mentioned many of the resources that you can find about Thrive and other tools and frameworks that Prevention Institute has made available on our website. And we're really interested in learning from you how Thrive could be used as a framework in your work on intimate partner violence prevention, and how it also could be used as a tool to support intimate partner violence prevention efforts. So please continue to text chat away on those questions, and while you do that, I'm going to turn it over to Jonathan.
Great, thank you. Thank you, Lisa and Ashley, for the presentation. This is a lot to think about. I mean, I think we always talk about kind of the root causes and again strive for those upstream factors, but it's just really interesting to kind of further contextualize that and fit that into a framework that you all have found really useful in getting to some of those community drivers. I particularly loved the way and really appreciated the way that you all talked about community trauma and conceptualizing that as an issue and kind of talking about that in the context of IPV and historical trauma and all these other things and structural racism. I really appreciate that. So I want to leave time for everyone to be able to ask questions. If you have a question, go ahead and you can either raise your hand or unmute your line and pose that, or we're monitoring the text chat, so feel free to ask away there. I don't think that, and Casey Castaldi and Casey Keene, correct me if I'm wrong, but I don't think there are any lingering questions that we had written down, because you all did a wonderful job really kind of answering questions as they popped up, so thank you for that.
Yeah, it was great to engage along the way, and so I don't think there's anything outstanding, but yeah, if anyone could just let us know in the text chat if you have lingering questions or thoughts that you want to add, we'd love to hear them, and we will be sharing the content of the text chat with all of you after the close of the session, so you'll be able to have that as a resource as well.
And our apologies, my apologies that I got Casey Castaldi's email address incorrect. So it's KCC@Prevention Institute, and she's going to be playing a lead role in a lot of our work. She played a lead role in the paper that we wrote, and she'll be playing a lead role in the work moving forward. So she's a great person to connect with if you want access to the copy of the report, or if you want to find out other plans that we have for using Thrive for IPV prevention, or if you have ideas, or if you want to partner, please reach out.
I think people are just excited. I'm seeing Jean Marie posting this, excited about the resources. People are really loving the material that you presented today, Lisa and Ashley. Thank you so much. And Jonathan, if you want to just go forward with your closing thoughts,
sure.
Be great.
Sure. I wanted to pose this question for you all real quick. Go ahead and respond to this in the text chat. After hearing all of this, again, it's a lot to chew on, and also as Lisa was mentioning, it kind of boils down some of these huge issues into kind of a simplified model. So after kind of viewing all of this and hearing all the conversation, how do you feel about community level prevention work, particularly around IPV? Go ahead and respond to that in the text chat. And I will go ahead and put up information on who to contact. Lisa, thank you for putting Casey's email up there. And again, that's up in the text chat as well. Here's contact if you want to find out more information. And also, as Lisa said, contact Casey with anything else that might come up, or access to some of those publications. Also be on the lookout for, we have a October Prevent IPV webinar that we'll be promoting really soon on another issue around engagement and prevention, and more details on that will be coming up. And always stay tuned to the DVM happenings on Twitter, and definitely subscribe for the Prevent IPV newsletter if you haven't already. Thank you to everyone. We are so grateful to have had Lisa and Ashley share everything with us, and I want to give a special thanks to Justine and Casey and Casey Castaldi over at PI, and everyone behind the scenes who has just done an incredible amount of work to pull all this together and monitor the text chat, and y'all are just wonderful to work with. Thank you, everyone.